When an abnormal complete blood count reveals multiple cytopenias, like anemia and thrombocytopenia occurring simultaneously, it initiates an immediate triage pathway. Here, we are looking for the dangerous presence of rapidly dividing cells that have violently overcrowded the bone marrow cavity. The presence of circulating blasts or unexplained cytopenias mandates a definitive next step. You must order a peripheral smear and a bone marrow biopsy to identify the malignant lineage. Acute lymphoblastic leukemia is the most common childhood cancer, with a peak incidence occurring between the ages of 2 and 5. The initial presentation is often misleading. Nonspecific systemic symptoms like fever and weight loss can easily mask the underlying malignancy as a routine pediatric infection. As leukemic blasts physically saturate the bone marrow, they disrupt healthy hematopoiesis. This results in profound pallor and fatigue as red blood cell production falls. This marrow crowding also results in easy bruising and petechiae from low platelet counts, while physical expansion of the blast population within the bone cavity causes deep, unrelenting bone pain. Success in recognizing ALL requires looking past the generic pediatric fever to identify this specific signature of primary bone marrow failure. Once the bone marrow reaches capacity, ALL spreads into extramedullary sites, typically beginning with peripheral lymphadenopathy. This spread often involves the reticuloendothelial system, resulting in hepatosplenomegaly. In male patients, clinicians must also check for painless testicular enlargement. If the malignancy arises from a T-cell lineage, it uniquely presents as a large mediastinal mass. This mass creates immediate structural emergencies, specifically airway compression or superior vena cava syndrome, which require urgent intervention. Definitive diagnosis requires identifying greater than 20% blasts on bone marrow biopsy, followed by flow cytometry to confirm the specific cell type. Because leukemic cells frequently cross the blood-brain barrier, a lumbar puncture is a mandatory next step to evaluate for leptomeningeal spread and determine the need for intrathecal therapy. The initial abnormal CBC dictates a precise compartmentalization. Clinicians must determine if the marrow is crowded and if the malignancy has already spilled into the central nervous system or the mediastinum. Severe leukocytosis requires differentiating a reactive immune state from a malignancy like chronic myeloid leukemia. In CML, leukocyte counts are massive, frequently exceeding 100,000 cells. The cellular pattern favors less mature precursors, showing higher proportions of myelocytes compared to metamyelocytes. In contrast, a leukemoid reaction, a response to severe infection, usually presents with a lower overall white cell count, generally staying below the 100,000 threshold. Because this is a coordinated immune response, the precursor maturity in a leukemoid reaction skews toward more mature metamyelocytes. The definitive diagnosis rests on the leukocyte alkaline phosphatase score and absolute basophilia. A low LAP score and the presence of basophils confirm a BCR-ABL-driven malignancy over a normal immune response. In older adults, chronic lymphocytic leukemia is frequently asymptomatic and found incidentally as a severe lymphocytosis on routine blood work. Physical exam findings in CLL often include cervical or supraclavicular lymphadenopathy and hepatosplenomegaly. A peripheral smear will reveal smudge cells, fragile lymphocytes that rupture during the slide preparation process. Unlike acute leukemias, the diagnosis of CLL is established through flow cytometry of the peripheral blood, making a bone marrow biopsy generally unnecessary. Clinicians must monitor for complications, including severe infection, autoimmune hemolytic anemia, and the potential for a Richter transformation into an aggressive lymphoma. Hairy cell leukemia is a distinct clonal B-cell neoplasm defined by a BRAF mutation. This malignancy causes significant bone marrow fibrosis, leading to pancytopenia and massive splenomegaly, which often presents as early satiety. Diagnosis combines the identification of hairy leukocyte cells on a peripheral smear with flow cytometry performed on a bone marrow biopsy. In the geriatric population, chronic leukemias lack acute urgency. Diagnosis depends entirely on identifying specific peripheral smear anomalies and distinct flow cytometry patterns. While combination therapy for Hodgkin lymphoma cures over 75% of cases, this survival is balanced against severe, lifelong complications related to the treatment itself. For the first decade post-treatment, relapse remains the primary cause of death. However, long-term survivors face an 18-fold increased risk for secondary cancers, including lung, breast, and hematologic malignancies, driven by previous radiation and chemotherapy. Chest radiation also introduces significant risks for coronary artery disease, valve damage, and pulmonary fibrosis. Patients may also report a specific reaction where involved lymph nodes become severely painful immediately after consuming even small amounts of alcohol. Moving to plasma cell dyscrasias, clinicians must differentiate between several protein-secreting disorders: multiple myeloma, Waldenstrom macroglobulinemia, and AL amyloidosis. Multiple myeloma is defined by greater than 10% clonal plasma cells and the CRAB criteria: hypercalcemia, renal insufficiency, anemia, and bone pain from osteolytic lesions. These lesions require a full-body X-ray skeletal survey for detection. Standard bone scans are ineffective here, as they only detect osteoblastic activity, not the osteolytic destruction seen in myeloma. Contrast this with Waldenstrom macroglobulinemia, which involves clonal B cells and an IgM spike. This results in hyperviscosity syndrome, but notably lacks the bone lesions found in myeloma. AL amyloidosis occurs when misfolded light chains deposit in tissues, causing restrictive cardiomyopathy, macroglossia, and periorbital purpura. Effectively treating the primary lymphoma is only the beginning of long-term care. In plasma dyscrasias, management focuses on using protein electrophoresis to predict and prevent systemic end organ destruction. Tumor lysis syndrome is an acute emergency caused by the overwhelming release of intracellular ions when high-burden tumors respond to therapy. This creates a metabolic cascade of hyperkalemia, hyperphosphatemia, and hyperuricemia. The excess phosphate then binds to circulating calcium, precipitating secondary hypocalcemia. These shifts can be lethal, leading to acute kidney injury, severe cardiac arrhythmias, and seizures. Prophylaxis for high-risk patients requires aggressive intravenous hydration alongside allopurinol or febuxostat to inhibit uric acid formation. Established TLS requires immediate rescue therapy, continuous telemetry, electrolyte correction, and the administration of rasburicase to break down existing uric acid. The final emergency is febrile neutropenia, defined by an absolute neutrophil count of 500 or less accompanied by a fever. This is a surgical-level priority. The immediate next best step is the stat administration of an anti-pseudomonal beta-lactam. If the fever persists past 4 to 7 days without a clear source, the protocol requires empiric escalation to antifungal therapy. In hematologic oncology, the treatments are often as rapidly lethal as the malignancies themselves. Patient survival depends on recognizing the infectious and metabolic fallout within the first critical hours of care.